Hello, everyone. Welcome to a WEDI Virtual Spotlight, the final countdown, CMS-0057-F, updates from CMS and WEDI stakeholders. This spotlight is sponsored by Itility Health and MCG. It's my pleasure to introduce the WEDI Board Chair, Mary Lee Stein.
Hi, everyone. I would like to welcome you to this very exciting topic today. Next slide, please. A little bit about WEDI before we launch into today's subject. We were formed in 1991 by the Secretary at the time of Health and Human Services, Dr. Lewis Sullivan. The first WEDI reports were folded into legislative language. We are named in the HIPAA Act of 1996 as an advisor to the Secretary of Health and Human Services, and that's a role that we maintain today. Our mission is to provide multi-stakeholder leadership and guidance to the healthcare system on how to leverage the industry's collective technology, knowledge, expertise, and information resources to improve the efficiency, quality, and cost effectiveness of healthcare information. If you'd like to learn more, please contact Bill on our staff at BALLDER@wedi.org. How do we support health IT? We are a convener and an advisor. And how that works is we convene the industry to receive guidance from our stakeholders. We do that through work groups. Our work groups create educational material as well as we gather information from the WEDI organizational participants and the industry as a whole at times to provide our advisory information to HHS. We do that through member position advisory events, and then we'll provide comments and letters to the various legislative organizations. Next slide. I would like to hand it over to Rob, who will talk us through today's agenda.
Thank you, Marilee, and let me add my welcome. This is really a tremendous event. We know we're in the home stretch before the 1127 compliance state. So we've assembled just a wonderful group of speakers to help us better understand where the industry is now and where it needs to go in the next few months. So we have we're very pleased to have two of the leading experts at the Centers for Medicare and Medicaid Services, Scott Weinberg and David Koppel. We are tremendous partners with CMS, and they are very generous with sharing their time and their expertise with the WEDI audience. We've also got a really excellent group of panelists to talk about some of the issues that they're seeing within their own stakeholder group, including Danny Kaywood from MCG Health, Pam Grose from the Cooperative Exchange, also the Vice Chair of Policy for WEDI, Michael Lanzer from Itility Health, Heather Kamas from the American Medical Association, John Raskoliak from SenCal Health, and Carol Wahman from Blue Cross Blue Shield of Illinois. Next slide. And I just wanted to point out that we do a lot of the great work here at WEDI through our work groups, sub-work groups, and task groups. And you can see here we have a wide array of work groups by topic, including everything from the HIPAA transactions to genomics, privacy, and security. We have launched a new one. We call it the Patient Experience Work Group, which discusses the critical intersection between health information technology and the actual care and experience that the patient has. And we also have one specific to prior authorization. And if you go to the next slide, what I'd like to do is invite, we have got, I believe, two of the co-chairs from that sub work group online, just to tell us a little about the work that they're doing and what they expect over the next few months. I see Heather, and I'll turn it over to you.
And thanks so much for joining us today. Just wanted to encourage everyone on this session that if you are a WEDI member, you are able to join the prior authorization sub-work group, and we are welcoming of all stakeholder types. This is definitely, we need everyone's voice to address this really complicated issue. We meet on the third Tuesday of every month at 2 p.m. Eastern. Today, our normal call is being superseded by this special event, but usually we meet on the third Tuesday of the month at 2 p.m. Eastern. And we have been meeting regularly, monthly for many years, working on various projects. I think for the past several years, definitely implementation of the CMS-0057 final rule has been top and center for everyone in our work group in terms of what we want to discuss. We have fielded several surveys on industry readiness. I believe the most recent one closed last Friday, and so that's been really helpful data in helping us in the industry as a whole, seeing where we are across stakeholder groups in terms of readiness. And we're also working on various educational tools as well. But I will pass it to Michael, my co-chair, to see if he has additional things he'd like to share with you about what we're working on right now. Thank you.
Yeah, I think in general, the key point is that the sub-work group is really intended to help aggregate feedback and input on what's important and what kinds of things our members would like to know about or would like some emphasis on, but also to help drive collaboration within the industry. This prior authorization work is so critical and important, and it's only successful if we can see a lot of collaboration and work amongst the various stakeholders involved in this process. So that's a key objective of the sub-work group, and would love to have anybody participate that's interested in the topic.
Thank you, Heather and Michael. Just to remind folks, we like to make these events as interactive as possible. We encourage you to ask questions or make a comment by using the chat feature in the Zoom toolbar. And as always, we will send the slides and recording of the event to all those that registered. Next slide. So with that, it's my pleasure to turn it over to David and Scott. And again, thank you both for being here and for walking through this very challenging regulation with our audience.
Right, sure. So if you don't mind, I can grab the screen here and sorry. Okay, great. Well, thank you, everybody. And thank you again to WEDI for having us back. Many of you, I think, guess you wouldn't be attending if you didn't know about 0057F, but we'll do kind of do our standard run through, and then Rob and company were kind enough to send some questions ahead of time, so we are anticipating some of your questions, which we'll hopefully be able to answer here. But we'll be around for questions. So if you don't know who you are, I see a lot of familiar names on this attendee list. But we're the Health Informatics Interoperability Group under the Office of Healthcare Experience and Interoperability. Where our mission is to promote the secure exchange, access, and use of electronic health information to support better informed decision making in a more efficient healthcare system. Or as I tell people, we're the team that does the interoperability rules, and that people usually understand then. So here's one of our slides. Here is our 10,000-foot overview of 0057F, the API policies, showing the extremely basic workflows of the APIs. So the patient access API, which was finalized in the original CMS interoperability rule from May 2020, for that patient to be able to get their own health information directly from their payer, the impacted payers under our rule. And then in 0057F, we finalized the provider access API, which will allow the provider to get almost the same information as the patient, also from the payer, with the exception of provider remittances and cost sharing information. Then the payer-to-payer API, enabling the payers to exchange, again, mostly that same information, but between themselves, if they're concurrent payers from that the patient has, or if a patient has a new payer, giving the payer the ability to get that patient's information from the previous payer. And finally, that prior authorization API, which I know this session is mostly about, and which you all are kind of working on implementing. In addition to that technological piece, and here's our 10,000-foot view of the non-technical pieces of 057F. So the policies to shorten the prior authorization a timeline. So when a provider requests prior authorization from a payer, they'll now have the payer will now have 7 calendar days to review standard requests, and expedited requests 72 hours. In addition, having to provide a specific actionable reason if they do deny a prior authorization request, as well as, and then finally, publicly reporting certain prior authorization metrics, which I believe our next slide kind of goes into detail. Actually, the next slide, so I was wrong here. So just the more details on the prior authorization API itself, as I think it was Rob who noted at the top of this call here. That January 1st, 2027 date is fast approaching. We're now under a year away from the requirement to establish the prior auth API, and that API, some of the requirements of that is being able to populate a list of items and services, excluding drugs. For now, I'll give you some more information there in a little bit, but excluding drugs that require authorization from payer, including also specific documentation requirements for items and services that require a prior authorization, and as well as being able to really affect the prior auth itself. So getting to electronic prior authorization. Those non-technical pieces for improving prior authorization policies. Well, today is February 17th, so these policies have now been in effect for a month and a half, and actually we've seen actually some impacted payers already. We've been taking a look, and we've seen some of those publicly reported metrics, which is pretty cool to see. So as I mentioned, the kind of shortened decision timeframes for the impacted payers, the specific policy reason, and then those metrics. You can find all this information on our website in the rule itself, plenty of our materials that we've put out. But so I won't read all these, but the list of items and services that require prior authorization, and as well as some other metrics which we'll be going through. So I'll just note that the deadline here is March 31st of this year to get this reported, reporting the calendar year 2025 data. So just a quick reminder, apologies, the formatting got a little wonky here, but so who they all are impacted payers, state Medicaid, fee for service, and managed care plans, CHIP fee for service, managed care entities, Medicare Advantage orgs, and QHP issuers on FFEs listed here. The various reporting levels to report on. So these are questions we get a lot. So I'm just kind of laying these out here again, but I won't read through these, but just know the kind of the differing reporting levels depending on the program. With that, yeah. So I think I'll turn this over to David, and he'll talk about those prior auth metrics, which.
Sure. Thanks, Scott. Yeah, here we go. All right. So we finalized some metrics in the proposed rule. I think it's I also want to be transparent that we, in our guidance, we have added some suggested information that we believe will make the required metrics more helpful to patients, providers, the public generally. And one of those is that we suggest that in addition to the percentage, that the total numeric counts are also reported, because we think that makes a significant difference. If, I'm just gonna make up numbers, 50% of 100 requests are approved. That's very different than 50% of 100,000 requests for the payer. And so we really suggest that in addition to a percentage, that payers provide totals in order to give additional transparency. And our metrics are generally complementary. We have the approved as well as the denied. So we would expect that those add up to 100%, with any rounding, of course. But the idea is that these metrics are supposed to capture a holistic view of the payers, the impacted payers' prior authorization program. So I know one thing we've gotten a lot of questions on, and so I'm just trying to say it more, is that the overall approved and denied should include everything else, like everything, I guess I should say. Because I know that in addition, there are metrics about how often the decision timeframe is extended, or how often there's metrics about appeals. And I think that we want to communicate that the top line number should be the top line number across all prior authorizations, which includes those that had the deadline extended and those that were appealed, because we want that top line number. And then within that, additional information that we are looking to be reported is those that were approved or denied within the regular timeframe that has been established by regulation, and those that were extended by the payer. Each program has different requirements and different processes for extending the timeframe, and so the exact definition is going to depend on the program. But we also want to know, and we think the public wants to know, how often those requests are extended. The deadline is extended for those requests. Next slide. I think we've got, So then the next metric are the appeals, and I think it's important to realize that an appeal only goes one way. That patients and providers appeal denials. As far as I know, there's nowhere where plans can appeal an approval, since they are making the decision. But what we're looking for here are the number where basically the denial is overturned, and the prior authorization is eventually given. and the percentage that remain denied after appeal. So the numerator for both of these should be the total number of denials that are appealed, and then the percentage should reflect how many of those appeals are either overturned or remain denied after the appeal. And so that we want to give ourselves, and again the public, a view of how often that happens and what the rate of success is for patients or providers that appeal a decision. And then finally, we are looking for the mean and median amount of time that it takes to make a determination or a decision. Those metrics should be measured from the time when the payer received the request. The payers are also permitted to only count when they have all the documentation required. So we understand that sometimes payers don't get all the information that they need, and so are not able to make a decision or a determination. And so if there is time when the payer is trying to request additional information, or when a prior authorization request is not complete, that time should not be counted against the clock that a payer has to make a decision. And so these times, the clock really should start when the payer has received all of the information that they need. That doesn't necessarily mean they have processed the information, but that they have received it from the provider. Next slide. And then, so we really have, because prior authorization requests fall into two categories. There are standard requests and there are expedited requests. So we have essentially asked for the same, or we require the same metrics be reported for both standard and expedited requests. Next slide. I think this is the same. Also, and again, we have a template with some of this additional guidance on our website, which is goes into a little more detail than the rule does. The rule itself does, and so clarify things like it should be calendar days, not business days, or calendar hours, which is apparently some concept that has recently reared its head. But in any case, it should be calendar days, calendar hours, which include weekends and holidays. Patients are, not patient conditions don't take holidays and weekends. So if a patient needs urgent care on a Saturday, that needs to be accounted for. And standard requests, there are for most impacted payers, we finalized a requirement that they be decided within 7 days. So that should be reported in number of days. There's no need to break that down into hours or anything shorter. And then expedited requests can be reported in hours or days. But the point is that it needs to be in calendar days, not in business days. Next slide. So again, this sample gets a little smushed in our slide, but if you look at the website, you can see that we've developed nice template that can be used. It is not required. There is no particular template that is required. We also have released metrics for Medicare fee-for-service that is different format. Payers should feel free to use either one of those, or come up with something else, We just ask that it be clear, user-friendly for the public, who are generally not going to be experts in exactly what prior authorization processes are, but want to get an overall sense of how a payer is, how they process prior authorizations and what the outcome is, because that's ultimately what patients most care about. Next slide. So we list here the compliance dates. I think Scott kind of went over these already, but the process policies for prior authorization, which are the decision timeframes, communicating a specific reason for denial, and publicly reporting the metrics, those all had a compliance date of January 2026. So they should be in effect now. The requirement to report API usage metrics is that goes into effect in 2026, but the deadline is March 31st. As well, and that is also the deadline for reporting the prior authorization metrics. I guess maybe that should be, we need to clear that up on this slide, but it went into effect January 1st, but the actual reporting deadline is March 31st. And then the technology policies from our rule 0057 have compliance dates January 1st, 2027. So those are staged for next year, 10.5 months and counting. I know, this is the countdown presentation, the final countdown. And then for the MIPS and promoting interoperability measures, those will be tied to the 2027 performance period or reported period, and then will actually be reported to CMS as part of those programs in 2028. Next slide. So then I think finally we have another proposed rule in under development. This is part of the unified agenda. We are desperately working to get the rule out as quickly as possible, as soon as possible. I am sure people want to know, but you'll know as soon as it's displayed. We promise. We're working on it as quickly as possible, but that is specifically around drugs, because we got a lot of comments in response to the previous rule, which only focused on items and services, that that the industry really wanted us to also look at the prior authorization of drugs, and that those needed guardrails as well as items and services. So we are working on a rule that will address the prior authorization policies for drugs. It will also address the interoperability standards. Will address some of the standards around the APIs and that were finalized in the interoperability and prior authorization rule. So we understand that the industry is looking forward to this rule, is eager to see it. Unfortunately, we can't really talk about it right now, but hopefully we will be able to do so soon. Next slide. And then we have some additional resources. I already saw in the chat that we had a question about whether these will be sent out, and they certainly will be. Scott, does cms.gov/interoperability still redirect to our website?
It does not, unfortunately. So, but if you
use the Google.
Yeah, if you Google 0057F CMS, you should find it. So.
Sure. So all right, yeah, and then I know we have questions. I think we have some pre-planned questions and some in the chat. I'm not totally sure, Rob, how much time, or Michael, how much time we have, but happy to address these questions.
Sure. We'll go over some of these questions before we go to our panel, and feel free to stick around and you can answer them through the chat, but we can go through the first two. Let's see. First one, is there a payer directory that we can expect to be made available across the industry for utilization for pair-to-pair API?
So that is something that we are looking at. Unfortunately, we don't have any information to share at this point, but I can assure you that it does. We are aware of the need. We believe that we believe in the utility of such a directory. It is very complicated and we are continuing to work on that, but hope to have some information available publicly soon.
Stephanie has a question. Is there any possibility of the 0057F mandate getting pushed another year? Is this even being entertained, or can we communicate confidently this deadline is firm?
No, that is, I can assure you that it's not going to be pushed back. There have been, Dr. Oz and, met with AHIP and other payers last year to get pledges around prior authorization reform, which really dovetail with the requirements of the rule. And he is very committed to seeing those industry pledges and the requirements of the rule go into effect as soon as possible, meaning the beginning of, for the API and the technology pieces, the beginning of 2027. So yeah, I can confidently state that those deadlines will not be pushed back.
All right, thank you. And the final question that we'll take in chat, but I welcome Dave and Scott to review the questions that still remain in the chat. Since the report is retrospective of 2025 data, the 7-day TAT for standard requests didn't start until 1/1/26. Therefore, for 2025 reporting, it would be with a 14-day turnaround time. Moving forward, 2026 and beyond is 7 days. I think that's more of a clarification.
Yeah, that's correct. And if I said it the other way, I apologize. But yes, because it is retrospective, it's actually reporting data from 2025. So yeah, we will certainly, that is what we are expecting to see. We also did not change the deadlines for or QHP issuers in the rules, so that's why I hedge my my statements. But so they do still also have slightly have longer time frames. So we won't be using, we're not going to be using these data to show some sort of mismatch with the 2026 requirements. We really do expect the 2026 metrics, which are reporting on 2025, to be a baseline. And then we would certainly expect the metrics that are reported in 2027 about 2026 to reflect whatever the regulatory requirements, statutory and regulatory requirements are for that particular type of payer.
Okay, sounds good. And once again, we do have questions from Susan, Ross, I believe a couple of other folks, and Michael on the chat. So while we're doing our stakeholder panel, I welcome Dave and Scott to address those questions in the chat. Once again, Scott Weinberg, David Koppel, thank you so much from CMS for pressing on and sending us all this fantastic information. And we look forward to more work with you in the future.
Sure, no problem. Thank you.
Yeah, thank you very much.
It is now time for our stakeholder panel, and let me have Those participants, please go cameras up for now. You see their names on screen here, and it's my pleasure to welcome Danny Kaywood with MCG Health, Pam Grose representing the Cooperative Exchange, Michael Lunzer with Itility Health, Heather McComas with the American Medical Association. I believe we'll be joined by John Waskowiak, and there he is right there, John Waskowiak with SenCal Health, and Carol Wahman from BCBS Illinois. Panelists, welcome, and let's jump into this. Going to address, welcome, John. This is for John, Kara, Danny, and Michael, and I like Michael to be the first to answer this one. In terms of what operational or technical aspects of 0057 implementation have been the most challenging, driven the most learning, or innovative for health plans so far in your work?
Yeah, thank you for the opportunity today. Really excited to be here. Thank you, Michael, for the question. Again, I'm Michael Lunzer with Itility Health. I would say probably the most challenging issue that we've faced to date is the lack of availability of provider systems and interfaces to test with, and the lack of awareness among the provider community of what's coming. It's made some of the challenges around iterating and improving user experience really challenging, because unless you can talk to users and work with them to see what their experience is going to be, or what they want, it makes it really hard to iterate and improve. But most importantly, it makes it really hard to implement these solutions without good, strong partners on the provider side. And there's just not a lot of availability and access from the EHR side of companies that are publicly sharing what they're doing or willing to engage in testing. It's been a fairly small group of EHR vendors, and even those are fairly closed as far as their level of engagement with those of us on the payer side.
Danny, are you seeing the same thing from your view at MCG?
I think I'll build on what Michael said. I don't know. I think we've been involved in some of the settings where the EHR vendors have been very forthcoming with sort of what they're working on, what they're testing. I think there's always opportunities, I think, for everyone to do that. But I was going to kind of take this question in a different direction and talk through and build on part of what Michael said right at the beginning in terms of I think one of our biggest challenges right now, and I know this is a very IT focused audience that we have, and it's really the IT folks of us dragging the people who are doing the work today into the fight here. I think fire is naturally a challenging thing for the clinicians that actually do this, that look at these requests, the physicians that actually submit them on the provider side, the reviewers on the payer side that do this. We see some health plans have a really strong sort of cross-functional team of operations, clinical, and IT. And we see it, and we've seen from our customer base another group that's far more IT focused. And I think those IT focused uh, plans are moving a little faster right now, but I think that's also sort of going to do them a potentially do them a long-term disservice in all of this from having to do rework. And it's really, how can we bring the people who are doing this work today in the manual and in the messy ways that this gets done today? How can we bring the people doing that into all of this to make sure that I think we're going to talk about testing in a little bit, but make sure we're testing in real world scenarios. I think Michael, you're focusing on the players, and I'm focusing on the process a little bit in terms of to say, are we stress testing this with the right level of complexity that is all being wallpapered over by fax machines and portals today?
All right. Well, you guys are speaking from one perspective. I'll ask from the payer perspective. So, Kara, welcome. Your thoughts on the operational technical aspects of the mandate that's been the most challenging from the BCBS Illinois perspective, or most learning or innovative?
Yeah, I think it's almost all of the above, but definitely the variations in the interpretations of the rule. In all my years of experience in the Medicare space, it's typical to see different payers and different parties have different interpretations about how a rule should be implemented or what the intention of the rule is, but we all get pretty close to each other. In this case, I think what has been really the most difficult is the variations, and even taking into account the variations now in the implementation guides, depending on which version you're going to be using. These are things that I think, as Danny was saying, if you get too far ahead of it, you're almost in trouble now. So it was like those of us that started and really latched on to this body of work and saw the opportunity, had to be really patient, though, also, so that way we weren't getting ahead and putting ourselves in a rabbit hole or backing ourselves into a corner where then we had to rebuild or find a new alignment with the industry. And I think, even David was just talking about just the clarifications on the PA reporting, that's like just a small piece of this larger body of work. So when you take into account the clarifications around the implementation guides and the different order sets and how this is going to be demonstrated, it has, to me, been some of the most challenging work, but it has driven us to be very innovative, very flexible and agile, and rethink how we do large scale efforts like this. So I think it's challenged us and changed us for the best, but we've definitely had to flex our patience.
Excellent. Is patience also an idea over at SenCal, John? How's everything going with you?
It's actually the same. All the issues are the same, but being in a small plan with a small IT shop, we're very vendor dependent, and also to compound it, we've actually working with our vendor, which has only been live over a year. And what we need to do is get that integrated. So that's also another component. It's not only working with the providers and connecting, it's now connecting back to our new system and ensuring the business understands that entire workflow and how our solution will meet this requirement, and support the business. Also, our providers, we're very, very, very close with our providers. So there's a lot of communication and hand-holding going on because, again, we are regional. So that provider relationship and ensuring smooth connectivity and usage and no abrasion is critical. That's a mandate throughout the organization.
Interesting. Thank you for that perspective. And speaking of providers, Heather, welcome to the panel. From the AMA's perspective, where are physicians most aligned and most challenged in their readiness? And what real-world impacts do you think policymakers are perhaps underestimating?
Thanks so much, Michael. Well, I think in terms of alignment, there is massive alignment because physicians, and I know across the healthcare professional space, are desperate for improving this burdensome process. They're desperate first and foremost because they see this process impacting their patients being able to access timely care every single day. And it's a moral injury when they see their patients not getting their care in a timely fashion. And secondly, we know that this process consumes an enormous amount of physician and staff time. So they are completely aligned in wanting this process to get better and faster and more efficient. So that's one, huge thing. And then also, I want to highlight, I realize this is a little perhaps wonky and the policy weeds, but I think it's important to mention the fact that at the AMA's most recent House of Delegates meeting, we have these meetings twice a year, and our physician leaders pass policies that are the basis for all the AMA's work and advocacy. New policy was passed that is asking the AMA, and I'm going to read this exactly, to advocate for a mandate on health insurers to provide a real-time online tool for coverage and payment policies integrated into electronic health records. Now, I realize those aren't the same words that we use when we start talking about the IGs, But heck, if that does not sound a lot like 0057, correct? And then also the policy says that we're supposed to advocate for this online payment policy tool to be a uniform interface that works across all insurers and physicians, ensuring consistent and streamlined access to coverage information for physicians and patients. Again, I think you can see that our physician members are completely aligned with wanting the goals of 0057. So that is the good news. I guess the big challenge here is that this policy was formed in November of 2025. So obviously, many physicians are not aware of 0057. I give you my Girl Scouts honor that the AMA has very much been trying to promote and publicize this rule and the benefits for physicians and patients since it was finalized in 2024. But the fact of the matter is, and I know that we all know this, dealing with our healthcare professionals every day, they're busy people, and unless it's right in front of them and available right then and there, it's hard for that to get their attention, frankly. And I think this kind of goes into your next question: is what's needed is in the next, few months, is that we really need this to become tangible and real for physicians and other healthcare professionals. They need to see their vendors bringing them information about this new tool. Having the ability to test this tool with their payers is really important. I think that, those of us in this techie world talk about 0057 in terms of the FHIR implementation guides and the APIs, and that's just not how most of our clinicians think about this or talk. I think we need to put it into common language, and also for it to be something that is available in their EHRs that their vendors are offering to them and informing them about so they can start using and testing the technology.
Excellent. Thank you.
And plus one to what Heather just said. I think my big takeaway from what you just said, Heather, is the way we've been talking about this with providers hasn't been effective thus far. APIs and FHIR and CRDs and DTRs and PASs, we've lost everyone, probably even half the people on this call already. As I started, only 6 acronyms, and we've lost most people. I think it's take what Heather just said that they were asking for and start talking about what we're trying to do here in those words.
Yep. And Michael, you had some comments at our pre-call regarding the plight of the provider.
Yeah, I think just echoing really what David and Heather have said is that the provider doesn't know what's coming. They're not aware, and this is such a huge improvement for them. I don't know how ultimately that communication has been lost on them, because this is going to impact their lives in the most positive way, and they don't even know it's coming. And I think, again, part of that is the EMR companies are still working on their solutions, and so maybe they haven't exposed it to all of their provider partners yet. Maybe their provider partners haven't been listening, but there is definitely a disconnect there that somehow we all need to overcome. Some more transparency or live demos online on webinars of the end-to-end workflow, maybe the provider experience workflow, and talking about this in positive terms versus the challenges that everybody's faced with. Because I think, we have a tendency in this technology space to talk about challenges. There's some really exciting things going on. There's a lot of companies that have made tremendous headway. There's some organizations that have deployed the CMS-0057 interfaces already ubiquitously across their policies and their procedures. So there's some great, exciting things that have happened, and we maybe need to focus a little more on the positive, and providers will maybe get more excited. I think if the provider organizations were more aware, they would be pushing this even harder, and all of us vendors would be challenged. All of us vendors, payers, partners, et cetera, would be challenged to move faster in this process.
Excellent. Heather mentioned, I guess, the gap in communication and outreach that's out there possibly, or just, providers not understanding what's, like you said, going ahead of them. I want to ask the group, starting with Kara, in terms of things that aren't working and things that are working, kind of the gaps and the alignments, what's clicking and what's not. What do you see from a payer perspective, and where do you see the greatest opportunity for continued progress?
Yeah, like a couple things, and a couple of thoughts too coming out of what Michael and Heather just said. I think some of the gaps and some of the things that keep me up at night as a payer is that engagement with our physicians and that level of skepticism that they may have, going into this. And again, then like back to the variability and how the EHRs are going to be integrating into the provider's workflow and making sure that whatever we do as an industry, we're making things better. My biggest fear is that we rush into something, we don't have alignment, or we don't have a North Star across the industry, and then we lose our providers in our first 5 transactions. And then it's trying to regain their trust and bring them back to the table and help them to see, why we're so excited in this. So that was just something, as Heather and Michael were talking, really kind of resonated and got stuck in my mind, is the level of pressure that is out there to make sure that we are making a change, we are improving quality, we are improving the provider experience, and we're engaging them in a way that is meaningful for them and brings value to them and to our members. So that's kind of like the first thing that it really is sitting with me right now. But as far as gaps and alignment, I think one thing that I'm excited about, I think my peers here at HCSC are excited about, is bringing the clinical guidelines into the provider workflow. That standardization, the digitization of the clinical guidelines, presenting them up front to ensure that providers and our members and patients don't feel like things are a moving target, that there's full transparency. I think there's a lot of work that still needs to be done in that space, but thinking through that, and HCSC did do a provider stakeholder analysis, last year across the nation. We did a double-blinded and we did a blue branded survey. And that was one of the number one things that we were hearing from our providers, is that they wanted to be able to see that clinical information upfront and understand it. So I think that that's a gap that we're going to be filling, that everybody's probably pretty excited about. It's a little bit scary because we've not done it at scale. We're talking, hundreds, for some health plans, probably thousands of policies and really difficult rules and difficult impacts from the different implementation guides on how we're going to be able to surface those or get to the right policy. But I think that that's a gap that's going to be closed, and we're going to see really, really great alignment is once we're able to get that medical policy into the workflow. I think that that's kind of where the magic is going to start happening, and we're going to really start to see that excitement.
Excellent. Thank you. John, your thoughts?
Very much the same. And also, you have to look at the providers. This interesting perspective. I'm a single plan, but they're going to be having to connect the multiple plans. You're like, oh, wait a second. I got providers. It's going to be Kaiser, the Blue Shield, Anthem. So we got 2 blues here, where and all the others. So you got to think about it as, gee, they should. You would think this would be on their priority. Also, you're talking, a lot are, we have Sutter, which is throughout the state. They're pretty significant, but they have different versions and they're different parts of their organization. So looking at it from their point of view, they're in the same boat as payers. Oh, I got to connect the multiples, but so do they. Now, what is that best solution for that? Right? Is it a one single Fast on Fire app, but everybody's going to have a different vendor they're connecting through back to a back end vendor? So when you think about it, if you don't have a plan and you don't feel, it's like the start of EDI many, many years ago, and then all of a sudden, how many EDI connections do I have? Or do I go to a clearinghouse, or do I go direct? This is that same situation, much less on the payer side, where, okay, I need to connect to all my providers. I also have 2 back-end systems. I need to share data. Then I have very unsophisticated providers. So my Sutter Health, they have a larger degree of sophistication, but then I have some smaller ones that are still having to do this, and it's still a benefit that it's nowhere near on the radar. They're still worried about submitting claims. That's my point of view. That's what we're considering as we're doing our outreach, is what are you doing for others? How are you communicating with others? Or I want to piggyback on the blues. Hey, you're doing it. SunCal, come along.
Okay.
You know what,
Thank you. Oh, go ahead.
John, I just want to say I totally agree with you. And like I think one of those things that is really out there that I want to see us be able to drive forward, and maybe this is for like your last questions or like the, our closing statements from WEDI, is that connectivity strategy, right? So for our providers, I think that is a big question for them, is the connectivity strategy and how they're going to be able to engage with all the different health plans that are out there and each other.
Yeah.
Yeah,
Pam, I was about to. Oh, go ahead, John.
so think about it. We all lucked into over EDI when I started, the earth cooled and I started in the EDI world. It was, you had what is now Change Healthcare. You had NEIC. You had, all these smaller clearinghouses, that you could help facilitate. And then it was just adding payers to that clearinghouse. So it was one connection. That doesn't exist here. It's a direct connection to every single payer. And I don't see any clearinghouse like Change or anybody on the horizon right now that's offering to do this for anybody.
Perfect segue there, John. As I introduce Pam Grose with the Cooperative Exchange, she has her hand up. You were just talking about clearinghouses. Pam, you had your hand up. Please go ahead.
Yeah, I just wanted to jump in there, and this is an area that the Cooperative Exchange is heavily engaged in. And to answer your question, yes, there are clearinghouses that are involved in this and are working to help facilitate the exchange of transactions in this environment, just as we have historically through the EDI world. This is an area of concern because a lot of the focus around these APIs is very much point-to-point FHIR connections, and that's simply just not scalable. As we've just been discussing, it's really many-to-many, and we can't scale that way. So intermediaries like clearinghouses are going to need to be engaged in the process and involved in making this transition happen. Just because it's a different transaction standard does not mean that clearinghouses cannot participate in that. And we certainly are heavily engaged in making that process work. So making sure that all the providers at their varying stages of readiness can communicate with all the payers they need to communicate with, and vice versa at everyone's varying stages of readiness. That's what clearinghouses do. And we're very much engaged in this initiative and making sure that this process is ready to go. And we'll talk some more about this as we get to one of the subsequent questions. But just wanted to point out that intermediaries are a critical part of this entire transition to make sure that we can handle the multitude of endpoints that are going to be needed in exchanging this data. Even though it looks different than what we have historically exchanged, that's still the role of the clearinghouses to help facilitate exchanging that data.
Excellent. Thank you. Michael, go ahead.
Yeah, I just wanted to comment because I find it fascinating that we learn things in calls like this that are miscommunications. Using the word clearinghouse totally changes the perspective in many ways of the way we all think about this. The 0057F and FHIR world always thinks about this in terms of the term exchanges and TEFCA exchanges, and we haven't internally in the CMS-005 world, 0057 world, talked about these intermediaries as clearinghouses because those have a direct distinction and unique approach in the EDI world. There are definitely many companies that are planning on and building and delivering solutions that are intended to be FHIR exchanges. So that's definitely a communication clarification that we need to work on.
Definitely. Wanted to ask John and Kara and then Danny and Michael for their thoughts on the following question in terms of kind of ongoing best practices. What decisions have you made or did you make early on? Architecture, partners, governance, sequencing, that have paid off the most so far? And I'll start with John. Anything you would do different? So, ongoing best practices, this is a long process. Is there anything from those elements, architecture, partnerships, governance, and sequencing, that was really a home run or something that you would do different?
Partnerships is the key thing. So we, I've been at the plan now just, it was a year in December, and the infrastructure was the only existing infrastructure partner was with what's now Cotiviti, from the initial mandate. And so thank God I can leverage that, and that is an option to add the modules. Because if I had to walk in the door, and also then because also there's other work going on. You have your daily production operations. Also at the same time, we had a DSNP mandate that we had to have live by 1/1 with a complete platform. I had to re-platform both the clinical and my claims and membership system over the last year. Thank God for partners, because now I can just connect and then work with my new partners on the back end to connect, for my and that was a learning. If I had to do it over again, gee, I'd love to do just that, but that's not how we live life, right? But having Cotiviti as a partner and being able to, basically add layers on to support this, and also the familiarity with them and their abilities to connect to back end systems, and then the work they're doing to talk to my MHK vendor to make a more seamless integration. They're all wins. That helps the infrastructure, the architecture, and we're now talking long term. Yeah.
Gotcha. Thank you, Kara.
Yeah, I agree. The vendor partnership was huge for us. So being able to really seek out like-minded partners that were out there that saw the same vision that we had, and then being able to identify which of those do we already have a relationship with, so we could have some early engagement as we get through, those longer procurement processes. I felt like was very, very valuable, spending that time just making sure that there was a cultural alignment in what we see, because there are so many variations in the interpretation and how people feel like this could be achieved. So that was something that was really important for us. One of the other things that in my role, I have Medicare oversight here at HCSC for our clinical operations team. And so one of the things that I was very passionate about, HCSC is obviously very, very passionate about, was our governance process for all the decisions that are made. So we look back at like things that we thought that we knew in 2024 compared to things that we actually know in 2026. Being able to go through, understand where decisions were made, where we may have learned more information as the industry has evolved, and being able to document that. The body of work that we're doing is so significant, that being able to have that governance and that monitoring of all the decisions that are made, it was something that we put a lot of effort into. And, I would strongly recommend for other health plans as you're working through this, because things continue to evolve. And so understanding how you got to down one path, and if it needs to pivot based on new information, and making sure that all of those appropriate parties are aware, I think is one of the most important pieces in helping us to stay on track and make sure that we're maintaining compliance with the intentions of the rule.
Great. Thank you. Danny and Michael, starting with Danny, what have you seen from your unique perspectives as the vendor? I'm sure you would say partnerships were pretty big, of course, but is there anything else that you've seen, that has really paid off, and seems to be going in the right direction?
Yeah, I think I'll reiterate, I guess, what I said earlier in terms of the decision to involve clinical people outside of your IT team, to involve operational people outside of your IT team in all of this, to me, is one of the the critical decisions to make, even if these Da Vinci implementation guides, what's interesting, they've been developed with an engineering mindset, right? We are going to make sure that these are broad enough that all of the edge cases can fit in. Existing prior auth process was developed with the opposite of an engineering mindset. And the only thing that all of your operational clinical teams, whether you're a provider or a payer, can agree on right now is it depends. Whenever you ask a question, it's, well, it depends. There wasn't really like this, these are legacy processes that have been built up over time, and I've seen it. I've actually done it myself as more of a product and IT person than a clinical background on my own part. At some points, been frustrated with it. It's like, can we get past the it depends and just figure out what it's going to be in the future? It's like, no, you can't. Is the uncomfortable answer? Is no, you can't. You kind of do have to know where all of the little tendrils of all like the ball of yarn, if you will, that's been batted around by a cat for 20 years. Um, how do we untangle that a little bit before we start solutioning all this? I think understanding how this work is done today and making a commitment as someone who's responsible for implementing these implementation guides to doing that, I think is a critical decision to to make, even though at some points you are going to go nuts with some of the things that have happened. That's good. That is going to inform your test cases that are ultimately going to decide whether you succeed or fail in this once we say, hey, we're all going to meet at the end. Okay, once we all meet at the end, does this work or does it not?
Excellent. Thank you. Michael, your thoughts.
Yeah, I love Danny's perspective on the ball of yarn. And I think it goes to another perspective that we've found that our payer customers have found to be really helpful, and that's looking beyond just the prior auth APIs and looking more strategically at their overall prior auth process. How do they manage policies, for example, right? So looking a little deeper than just meeting the requirement, how can we leverage this moment in time to re-engineer a few things to ultimately end up with a better payer process and a better prior authorization process? There are so many things that if we can um, broaden our perspective of not just meeting this requirement, but improving process, that actually become a scenario where rather than having to invest in a new API requirement and get only an ROI from that, they spend the same amount of money and get tremendous ROI from upstream processes and interactions with their provider partners, and their internal stakeholders. So I think that's probably the biggest advantage that we've seen payers when they look a little broader to get a bigger value from this, not just a minimum API-based requirement.
Excellent. I'm going to call an audible and skip one of our questions and jump right into the big T word, testing. So the group, what are you seeing currently in regards to testing, and how can we ensure real-world testing takes place before 1/1/27? The first one I want to ask, and also offer a little bit of clarification on the unique role they play, is Pam, the unique role that intermediaries play in the world of 0057 testing. And then after that, I would like the rest of you guys to offer your thoughts currently on testing.
Thanks. Yeah. As I mentioned earlier, clearinghouses really play an integral role in all of this, not only facilitating the physical connectivity that we talked about earlier, the many-to-many endpoints, but also the managing the varying stages of readiness that different trading partners have. We have smaller providers that will be ready much later in the process, bigger providers that are ready earlier in the process, and similarly with payers. So clearinghouses help bridge that gap and do data transformation when it's needed to get the right data in and the right data out, depending on what each of those trading partners needs. And as we look at testing, intermediaries like clearinghouses play a really critical role there as well, making sure that the right test cases are identified, that the trading partners are aware which trading partners are ready for testing at which times, helping to facilitate that testing, getting the right data exchanged with trading partners that are ready to test, and again, helping facilitate getting that data exchanged and even transforming the data when it's needed so that as one trading partner is ready to go to production, that can happen even if the other trading partner is not. And specifically for the cooperative exchange, as we've looked at this specific initiative at 0057F, and looking at the different implementation guides that are there, we really wanted to make sure that the needs of the clearinghouses and the needs for facilitating that data exchange were incorporated into the workflow and the process. So we're initiating a project with HL7 Da Vinci's Trebuchet team to test out those use cases and make sure that everything works as expected with an intermediary in the mix. So we are undertaking that and getting the project underway. It allows us to validate that the workflow is that's needed is accommodated, and that all information that's needed in that workflow is contained in the implementation guides that are being used. So we are getting that project underway and beginning that testing with the Trebuchet team to allow us to fully end-to-end understand this is what the whole process will look like with an intermediary in the mix. So we're very excited about that project and excited about demonstrating the benefits of a clearinghouse being in the process as well.
Excellent. Thank you. Kara, how are things in terms of testing at BCBS Illinois?
So for testing at Blue Cross Blue Shield Illinois and for HCSC, I think that we're at this point where we're really starting to seek out who those critical partners are to be testing with and making sure that we're not just testing the happy path, but also really spending some time and looking at those edge cases that are out there. Those have been some things that we've been wanting to focus on. Is there is a lot that actually happens, to Daniel's point, in the day-to-day that doesn't fit perfectly within, the expectations of some of the implementation guides. And so making sure that we can identify those cases and document them correctly and get them tested is a high priority for us.
Sounds good. Heather, you have your hand up.
Yeah, three things came to mind here. And first of all, I think this has been a fabulous event. I would say one of the most important takeaways for me, and I think all of us need to hold it in our hearts, was the question about a possible delay. Folks, you heard it loud and clear here from David Koppel at CMS. It is January 1st, 2027 for the implementation deadline for this rule. Super important that we all take in that message and say, okay, this is for real. And so testing is so important, right? Because that is the go live date. And to pick up a thread that Kara mentioned a while ago, this idea of like the first 5 transactions that a physician or their staff do in production. If those are bad experiences, that is not going to be a good situation because physicians and their staff do not have time to try to figure out wonky technology. They're going to abandon things if those first in production experiences are going poorly. And they do not like their fax machine. I promise you that they hate it. But they will go back to using their fax because they know it works. And so that's why it's so important that we all be getting on the testing bus right now. And one thing I mentioned, it's not quite live yet, but from a WEDI perspective, there is a WEDI testing directory on the WEDI's kind of bigger 0057 landing resource page that's going to be coming soon. I think, it's a questionnaire that folks can fill out, the different stakeholder groups indicating where they are, what they're ready to test, who they're looking to test with. It's sort of like, like match.com for API testing. And I think it's going to be a really great tool, and I encourage everyone to check it out when it's available soon.
Excellent. Michael, your thoughts from the utility perspective?
Yeah, I think from a testing perspective, the Da Vinci work groups have been fantastic. The early connect-a-thon testing that was being done was really groundbreaking for this space. There's been a huge wave of more organizations that are ready to test, and so we're seeing a lot more testing. One of the things that we've been participating with that I think is a really interesting initiative, and that's the Drummond Group, which is looking to kind of create a certification process for testing, which would allow us all to lean in on a single direction rather than having to do one-off testing with each of our trading partners. Up until now, it's been pretty much technology partners seeking each other out, working through the Da Vinci, but lots of individual initiative that's necessary to get this testing completed. And it's great to see the Drummond Group stepping up as a possible source of that unified certification and testing.
Excellent. Now, folks, I know that it's advertised to end at 1:45, but we're going to go a little over. I'm sure you're not going to mind all this fantastic information coming your way. Just a couple more questions, then we have one question in the audience from in the chat. This goes to, and hopefully I got everyone talking about their testing. Now, a lot of folks listening here might be a little scared, might not be ready or be a little behind. So for Michael and then Danny, um, what are the 2 to 3 things for any organization that might be behind right now? What are 2 to 3 things they should focus on over the next 10 months?
I'd say there's a couple of key things. One is find a vendor partner, start participating in some communications with vendors because that's a critical time element. There's only so many of us vendors out there, and there's a lot of companies that are still yet to engage. So it is going to get to be a scenario where there is a bit of a shortage of vendor partners. So get in line now as quickly as possible. And then there are a couple of other things that payers can do to get started on this. One is start organizing your prior authorization requirements, specifically around the CRD. You know, a lot of organizations have a spreadsheet for is auth required, but they also have other extended systems that have data around prior auth rules. Start consolidating those rules so that when you find a vendor and when you've engaged with a vendor, some of that data is available. And in the same vein, your medical policy data. If you don't exclusively use an organization like an MCG, start looking to figure out where all your policies are, working with state Medicaid organizations to get better access to medical policies within the provider manual, put a little pressure on your state Medicaid organization to organize their provider manual in more of a policy organization. So there's a couple of things that you can do to start that initiative because it's not a super easy process. There are vendors that can make it easier for you, but get started now, I think, is the most important piece of advice.
Excellent. Danny.
Yeah, get started now, and procurement processes for most health plans are quite long, so agree with Michael. Get started now. I think the other thing to think about is doing broader than policy almost than what Michael was talking about, but do an internal, state of the union for all of your systems. You don't need to know who your interoperability vendor is and I want to go back to what John had said earlier about MHK and bringing along, your source of truth platform for what is the status of my authorization. Most health plans have one of those. Where does that status? Can you push cases in? Are there APIs that you can use to push cases in? Are there APIs you can use to get decisions out? You don't necessarily need to know who your interoperability vendor is going to be. You should start figuring those pieces out as well, but you don't need to know who they're going to be to get your sort of internal state of the union. Here's how I access benefits. Here's how I access provider network. Um, Here's how I can access my source of truth for authorization decisions. And if you come up with we don't have an API access to any one of those three things, provider network comes to mind. Um, start doing that now. You can again sort of start doing that before you do that. And even when you procure an interop vendor, that's going to be a tentpole in that project. So start thinking through, let's say you hire one of the interoperability vendors like Itility, like Michael said, there's a handful of them out there. I think, let's say you hire one, how are you going to walk them through your internal systems? Start doing that now too.
Excellent. Now, before we go into our final question, I'd like to pull one from the chat. This is from Sasha. Since this is a reportable patient access API metric, has anyone experienced similar challenges engaging members to use the patient API? And do you anticipate any impact on reporting? Probably goes toward Kara and John.
I'll go first. So I've been in 2 health plans since the patient access API. Outside of meeting the requirement of putting it out on our website, making it available per the mandate, that's been the outreach. to the member. So the patient access. Providers, I started outreach last year, early on, because I knew this was coming. But also too is the plan had a very, very proactive and robust provider outreach in place, because we're also doing this, in California, you have the data exchange mandate, where you're saying, you're supposed to reach out to all the providers, and then the state puts it in the MCPs, it puts it in your contract is you as the plan must, facilitate, you are required to do all the outreach for the data exchange. And then they also put in there for education and outreach to connect for 0057. So they didn't make the providers as responsible as they made the plans if you're a government entity. So that has resulted in a little bit of a tangent. It's not so much on patient access, but everything else. And so we're dovetailing all those mandates together in our communication.
All right, excellent. Thank you, Kara.
Yeah, so I haven't seen issues with reporting of our patient access usage, but I think what I have seen is some conflicts with the patient access API usage, which might make it look lower than what the patients are actually accessing, right? So if you have a health plan, you have a very robust member portal already, a lot of that information is there in a usable way for members to be able to access it without having to download it and connect it to a separate app. And so knowing that they have that availability to do that and use the app of their choice, I think it's great. But I think some of the reason that we might not be seeing across the nation really, really high usage of that is because we do also have those patient portals that members or that health plans and that providers already offer that has a lot of that information. So I think it'll be interesting as we continue to expand the data that's flowing into that. If our internal patient portals keep up with it, or if members feel like they need to be going out and accessing the API. But I think that might be why we see some of the variations in usage for the patient access API. So not sure if that helps, but hope that helps, Sasha.
Great, thank you. And in closing, I'd like to ask each of you the last question. What can WEDI continue to do this year and in coming years to support the industry regarding 0057? Let me start with Heather.
Thanks, Michael. So I think, first of all, I'd say continue to offer great events like this, particularly involving CMS and getting clarification, I think has been a fabulous part of today's discussion. Also continuing to support the prior authorization subwork group. Just a short plug, our next meeting is on St. Patrick's Day, March 17th, 2 p.m. Eastern. So please join us if you're a WEDI member. And that is really an important chance for folks from across the industry to come together in a safe forum, discuss what they're seeing. And I think that's a lot of what the subwork group has been doing the past several years, is talking about implementation, what's going on out there. And WEDI's done a lot of work to take the pulse in the industry of readiness, and we keep on fielding surveys to see where folks are in terms of their readiness. I think that's going to be an important ongoing activity. Also, I know WEDI is working on several different educational tools targeting different stakeholder groups. I think that those are going to be really helpful. And again, I think this the testing directory, when it's up and available, is going to be very helpful to help folks find each other and get to work on this really critical testing.
Excellent. Thank you. Pam.
Yeah, I'm going to reiterate what Heather said, to encourage everyone on the call that's a WEDI member to become involved in the prior authorization subwork group. It's an opportunity to interact with all of the different stakeholder types. That's one of WEDI's strengths, is we bring together all of the different stakeholders to come together and have discussions about challenges like this, and talk about what the challenges are, what are best practices for overcoming that, and look at it from a broad perspective, not just one stakeholder's perspective, but all the way around, to truly help everyone understand what the challenges are and what can be done from all aspects to help overcome those challenges. So I really want to emphasize getting involved in the subwork group and participating in those discussions, bringing your challenges forward, bringing your ideas for best practices forward, and having those discussions in an open environment.
Excellent. Kara.
Yeah, I think expanding kind of on what's been said so far, these sessions I think are really great, but I also think that they provide an opportunity to socialize the realization of where we are as an industry. I can't remember if it was David or Scott who said, this is not moving. And, Dr. Oz is heavily invested in this, and coming from a Blues plan who has signed those commitments also, we are heavily invested in this. And like Michael said, a lot of us are looking at this not as how do we check the box, but how do we change how healthcare is delivered today? And that is not a small feat. If we're unwinding 20 years of yarn, in 2 years, that's a lot of work to be done. And so I think that there is a great opportunity for WEDI to continue to help bring the industry together to work through some of these nuances, but also to provide that realization of what we're doing. To me, the worst case scenario is that we rush into something and then we have a poor provider experience and we lose that trust on January 1st. And so making sure that we understand where things are flexible, where things can be scalable, I think is a really good opportunity for us to have those conversations together. And I think WEDI really brings that mixed bag of participants to the table to have these conversations. So I would say we need to continue to do that. We need to continue to unpack, where there still are some barriers to 1127 and what that could do to our provider experience if we aren't thoughtful as an industry and getting alignment there.
Excellent. Danny.
Yeah, so there's several different things that come to mind. I think the number one thing here is talk to your providers if you are a health plan. Talk to your providers. And I think how WEDI can help in this is sort of continuing to give sort of a good template for how to have some of these conversations. I know this has been a prior authorization API heavy conversation, but there's also provider access. There's also patient access. Someone just asked a question about, but really it's how do we talk to, I agree with either Heather or Pam. I can't remember who said it, that hospitals are probably the most likely to be ready to do some of this stuff first. How do we talk to providers? How do we sell providers on the overall vision? Yes, prior authorization will be easier. Yes, you'll probably have access to some payer data that you can use to actually fulfill some of those prior authorization requirements, things that we've heard for years that providers are interested in. How do we talk to them and have the entire thing? WEDI will do some of it, and Michael and Bill and Rob and team do a great job of it. Heather and the AMA are going to do some of it, but nothing is going to replace health plans, yourselves talking to your individual providers, talking to people at the hospital associations for your states, those types of things. Go talk to your providers and start to talk to them about what's coming. And WEDI can help us, I think, as an industry, Michael, just kind of help continue giving us a good template for how to have that conversation and maybe some of the objections that are going to come up as we do it as well.
Yep, we'll be there. And to close, Michael Lunzer.
Yeah, I would just echo what Danny just said. I think ultimately the payer provider collaboration is what's going to make this successful. And right now, the payers are working very hard on this with a lot of their vendors. We haven't seen a tremendous amount of payer provider collaboration on this, again, because providers aren't aware to a large extent that this is coming. So if WEDI could help us engage more with the provider community and maybe even have a payer provider version of an event like this that has more providers engaged, talking about it from their perspective, or maybe just what they know or don't know. Because I think that's really probably the next big thing. The other thing I think is really important, back to what Kara said, if providers have a bad experience, they may just disappear from this overall experience and not come back. I think maybe setting expectations among the industry that this is going to be an iteratively improving scenario, right? So providers, again, if they're brought into this discussion early, can maybe have an expectation that that they're going to start using something that is not going to be perfect and it's not going to be 100% comprehensive, but it is going to, their participation in this will get us to a point where we ultimately achieve those perfect and comprehensive outcomes.
Challenge accepted. Excellent. Well, all of you, Pam, Danny, Michael, Kara, John, Heather, thank you so much for being a part of this panel. And thank you for sticking out with me a little longer than we had scheduled. Folks, this concludes our virtual spotlight on 0057. Be sure to visit WEDI.org and click on events to view all our upcoming educational offerings. There will be more 0057 content coming throughout 2026. Thank you to our sponsors for today, Itility Health and MCG. And coming in March, I think Michael mentioned state Medicaid. So we'll be looking at 0057F from the state Medicaid perspective on March 19th from 1 to 2:30 on Zoom. On behalf of everyone at WEDI and the panel here and CMS, thank you once again, Scott and David. Have a fantastic rest of the week.